Hello, I'm Dr. Forrest Tennant. I'd like to welcome you to this webinar on adhesive arachnoiditis. It's a pleasure for me to present this because in some ways this is a little bit of a culmination of about 10 years of active research on a disease that not too long ago was obscure and under the radar and not even known by anybody. Unfortunately, this disease has reemerged in this century, and it's now in every community, and practically all patients and medical practitioners need to know a basic foundation about this disease, and that's what this webinar is all about. You'll notice there on the slide that there's a number of people behind the scenes that are helping put this webinar out there for everybody to see. We do have some learning objectives, and I think they're very important. We don't cover everything about this difficult disease, but it does cover the basics. Number one, this is a difficult disease to manage, and it's not so difficult once one realizes that it does take a combination of a local medical practitioner, a patient, and a family, and today, in my opinion, some of the social support groups are necessary for someone to really grasp this disease and to manage it. Again, it's a difficult situation. Today, we have lots and lots of people out there with back pain. But who among those patients has adhesive arachnoiditis or who has Corticoids syndrome? In other words, today we have been able to differentiate and come up with a symptom profile to where any medical practitioner can differentiate who probably has this disease compared to a lot of other people who may have back pain. And lastly, one of the reasons we can present this seminar is that research has come far enough along that we've developed what I call a first generation management system or a management protocol. In other words, research has brought us to a point to where we can get started. It's elementary, and treatment measures will be much better 5 or 10 years from now, but at least we have the basis to where everybody who has this disease can start getting some treatment. Now, let's start with the basics. Just what is adhesive arachnoiditis? Well, now, first off, the arachnoid is one of the layers of the covering of the spinal canal or of the meninges around the brain. Adhesive arachnoiditis is actually a mass or a clump of what we call nerve roots attached to the covering of the spinal canal. And we call that the arachnoid neural covering, if you will. And this mass is actually a clump of entrapped nerves. And that's where the disability and the terrible pain comes from. We'll come back to this definition in a little bit because it's terribly critical that people fully understand what this disease is all about. Now, we're able to put on this webinar for 3 basic reasons. And number one, not long ago, this disease was considered a rare disease. In fact, it was unheard of probably in 1995. But today it's emerged in every community. Every medical practice has patients who have this condition. And so now it's a problem for everybody. Another reason why we can do this seminar is we know how to diagnose it. Even though it's been known for many years, most of the early studies in the 1800s and early 1900s had to be done on people who died from the disease. Today, we have firm criteria on who has the disease and who doesn't have the disease. And then lastly, we do have a first generation treatment protocols have been developed. And this gives everybody some hope because everybody who has this disease can start getting some help. A little history is not only interesting, but I think terribly valuable in this seminar or webinar. First off, the joke wasn't too long ago that arachnoiditis is a spider bite. Well, that's kind of, you would think that if you were just had heard the term, but the term arachnoid actually was coined by the Dutch clear back in the 1600s because under a microscope, the arachnoid lining kind of looks like a spider web. And so where the term comes from. It wasn't the disease, it was actually the layer of the spinal canal covering, or the meninges over the brain, that had this layer that sort of looked like a spider web. So that's where the term arachnoid comes from. And itis just means inflammation. So the term arachnoiditis really isn't new, and it simply means inflammation of the arachnoid layer. Now, in the 1800s, this disease became known as the devil's disease, a dread disease, and almost the worst fate that could be stored upon somebody. And it was a disease of great dread because there was no treatment, and people ended up with great misery and suffering, and they died early. And the cause in those days was syphilis and tuberculosis. It was usually infectious. And it did cause adrenal failure, and in fact, some of the cases of adrenal failure that were discovered in the early cases of adrenal failure were actually caused by arachnoiditis. Coming into the 20th century, it was known that the arachnoiditis term really wasn't quite correct because pathologists realized that this disease would not only affect the arachnoid layer, but it might affect the outer dural layer and in effect erode right through the spinal canal. And we don't see quite that bad of cases today, but we do see the involvement of both the arachnoid and the dural layers in the spinal canal covering. Now, between 1930 and 1990, this disease did emerge in America. And there was a man by the name of Aldretti and another, Dr. Burton, and some other physicians who recognized it, wrote about it, characterized it. But the cause was interesting and kind of sad, and that was there were dyes that were put into the spinal canal for X-ray purposes, and occasionally that caused adhesive arachnoiditis. As a matter of fact, I saw my first cases clear back in the 1970s and 80s because of these myelograms that were done with insoluble dyes. There's an interesting date that has really caused quite a change, and that's the date 1987. In 1987, the MRI was invented and developed. That meant that X-rays of the spinal canal or of the spinal cord could be done without injecting the insoluble dyes. And after 1987, adhesive arachnoiditis essentially disappeared. That's why modern day medical practitioners hardly know about it, because after 1987, we just didn't have many cases. All of my cases that I had either passed on or something happened to them, but they were not around. But beginning in the year 2000, it became obvious that adhesive arachnoiditis was re-emerging and getting more prevalent all of the time. And I'm going to say much more about that. But again, I date the re-emergence just about the turn of this century. And again, as I said before, these cases are now in every community, and all medical practitioners are going to have to know the fundamentals of adhesive arachnoiditis. Now, why has it re-emerged? And I've listed here 7 different reasons why I've come to the conclusion that adhesive arachnoiditis is re-emerging. Some of these are a little sad, but I do think they're pretty factual. And above all, identifying the causes of re-emergence allows us to also start thinking in terms of how we're going to prevent this problem. And I'm going to say more about that in a few minutes. First off, it's a disease of aging. And I hate to say it, but if you hit the age 60, you go into a risk pool of developing this disease. You really have to learn to take care of your spine after age 80 or age 60. And that has to do with this disc right down at the bottom. Is that past age 60, disc degeneration, intervertebral disc degeneration is very common. Another problem today is all us modern people are sedentary. We have jobs that sit in front of a screen just like we're doing today. We don't walk like we used to. We drive cars. We don't ride horses. We sit around and watch television. We sit in front of our computers. And frankly, we're a sedentary society, and that is a risk. And I'm going to show you a picture in a couple of minutes on why too much sitting is a risk for this disease. Another thing, the good news but bad news, is trauma recovery. Today, you can have an accident out on the freeway, 911 can be called, your life can be saved, but you may be left behind with spine damage that gives you this disease. Today, everybody is well aware that the necessity to do what's called epidural injections and spine surgery are risks. Anytime that you have to do surgery on the spinal cord or canal or on discs, anytime you have to put a needle into the epidural space, there is some risk of developing this disease. Another thing that's a little bit mysterious. We seem to be having an increase in the number of people who have genetic connective tissue or collagen disorders, of which the most common name is Ehlers Danlos Syndrome. Now, whether this is actually increasing in the population or whether we're just more aware of it is something I don't know. But all I can tell you is this. Those people who have these genetic collagen connective tissue disorders are at very high risk to develop inflammation of the lower spinal canal and adhesive arachnoiditis in particular. Also, these individuals get what's called a Tarloff cyst, and I'll mention more about that in a few minutes. Also, another thing that has led to the reemergence may be a little bit technical, and that is we now have diagnostic criteria. If you can't diagnose a disease, you don't know it is there. Well, today we can diagnose it, so yeah, we know a whole lot more of it is in the population than we used to know. So the fact that we have diagnostic criteria has led to what is at least a perceived reemergence. And down at the bottom, intervertebral disc degeneration. The development of arthritis as all of us get older, sports, activities, everybody knows about protruding discs, or what's called a slip discs. We didn't usually think too much about that in the past, but today we know a lot about those discs. We know they are inflamed, and it appears that about half the causes of adhesive arachnoiditis today are a long-term sequelae that is initiated by discs that protrude into the spinal canal, and you'll actually see some pictures of this and some discussion here in about 2 seconds. Now, I'd like to have everybody carefully focus on this slide. To understand adhesive arachnoiditis means you have to understand this picture. Now, this is a picture from a side view of all of our spinal vertebra and our spinal cord and what's called our cauda nerve roots. Now, here is what I wanted you to notice several things. First off, this is your vertebra, your big bones that support our entire structure. And they're divided into segments: cervical, thoracic, lumbar, and sacral. Now, adhesive arachnoiditis is almost totally confined to the lumbar sacral region. And I want you to notice something. There is a natural curvature to the spine, and right down here at what's called lumbar 5 and sacral 1 is your last intervertebral disc. Last meaning going downward. But it's right here, the spine takes a turn, and it's right here is what you sit on. And every time we sit in a car, or Mike sitting right in front of you right now, I am putting pressure on this curve right here. This is why the most common slip disc or protruding disc, or an L4 and L5 as we call it, and this is where most of the adhesive arachnoiditis occurs, is right here, L4, L5, and S1, right in here. Now, the other thing that's not well appreciated is that the spinal cord itself stops at about the middle of your back. It stops right up here, and there's a technical term at the end of it called the coda medullaris, but you don't really need to know that. What you need to know is that below the spinal cord hangs a whole bunch of string-like nerve roots. Now, collectively, this group of nerve roots hanging down is called the cauda equina. It's called the cauda equina because in Greek or Latin, it looked like this was a horse's tail. So cauda equina means horse's tail, And that's what that is. It's a whole bunch of nerve roots hanging down. Now here is a picture from an autopsy of a person who has died, obviously, but here is the spinal cord ending right here. And these are nerve roots hanging down. They're just suspended. Now, what you don't really see is that right along the back here and right along the front is the covering. And this covering is comprised, at least down at the bottom, the arachnoid and dura layers, and it's a pipe. And you think of the spinal canal as a pipe. And then that pipe is closed, and there is spinal fluid. Now, the good Lord has us make spinal fluid about every 4 to 6 hours. Spinal fluid is an essential, critical fluid, and the good Lord has us make that every 4 to 6 hours when it only makes new blood about every 3 months. So spinal fluid is a precious fluid inside the human body, and this horse's tail is suspended in fluid. And this is a critical concept in how we treat and manage and think about adhesive arachnoiditis and inflammation in this area. Now, I want you to understand something, and you're going to hear me talk about this. When I got into looking at adhesive arachnoiditis, I didn't realize that this was going to lead down a path to understanding that in the cauda equina downward, there are several conditions that cause inflammation of these tissues. Tissues in the canal include cysts, these nerve roots, the covering, and the discs themselves. All may get inflamed. And so what we're really talking about here is, in modern medicine, we're going to be tackling inflammation in the bottom part of the spinal canal. Now, here are some pictures just to make sure that we all understand exactly what adhesive arachnoiditis is and how it begins. And this is a normal canal. Let me make sure we get our bearings here. This is the end of the spinal cord. This is fluid in here, and there are the nerve roots hanging down. And they hang down throughout the lumbar spine and into the sacral spine. Now, here's what adhesive arachnoiditis happens to be. It is when some of these nerve roots that are hanging down get attached to the covering right here. In other words, you actually have two separate anatomic body parts that get glued together. And they get glued together by inflammation and adhesions, and that's where the name comes from. In other words, right here, you have nerve roots that are in a mass stuck to the lining. Now, these nerve roots that are coming out of this mass don't function very well. They're damaged or impaired inside the mass where the roots attach to the covering. Now, how does it start? Now, adhesive arachnoiditis can start several different ways. Now, it can start when something happens to the covering of the canal. For example, trauma, an automobile accident, falling out of a tree. I hate to say it, but a needle puncture, even a spinal tap, or an epidural injection at childbirth can irritate this covering and set up down the line adhesive arachnoiditis. Chemicals can seep in. This is the risk with epidural injections. You put into this epidural space an anesthetic, a cortisone derivative, and it can seep into the canal. It can seep into the spinal fluid. If you have a connective tissue disease like Ehlers Danlos Syndrome, you can start having collagen disappear in the covering, and you can have a cyst here called a Tarloff cyst, and that can get you started with this process. You can have an infection like a viral infection or a Lyme disease, or in the old days, syphilis or tuberculosis that infected the covering of the spinal canal. Today, we have a few autoimmune diseases, of which such things as systemic lupus, psoriatic arthritis, or even rheumatoid arthritis that can affect this covering. And so you can have any number of conditions that start out by attacking, if you will, were involving the spinal canal covering. That's not the common way, however. Today, this is the most common way that you end up with adhesive arachnoiditis. You end up with a protruding intravertebral disc. Now, the intravertebral disc sticks into the spinal canal. Now, it can do one of two things. These protruding discs can compress these caudoequine nerve roots and make them stick together. But the story, unfortunately, is worse than this. The protruding discs have been found to be inflamed. And so, somehow or another, when we get our arthritis or our trauma or a disease like rheumatoid spondylitis, which is a spine disease, and we get discs that slip into the canal, that disc not only compresses or puts pressure on the nerve roots, it's inflamed itself, and apparently inflammation kind of spreads. And you've seen this. Anybody who's had a boil or a pimple that got infected or a bite of some kind knows that the redness can spread. Well, this inflammation of this disc can spread right into the nerve roots. And so today, the most common predisposing factor in developing adhesive arachnoiditis is protruding discs. For all those people out there who have protruding discs, and like I say, practically anybody who's over 60 is a risk to develop these, needs to know that you are at a risk to develop this problem, and you need to be on a prevention program to make sure that these discs don't do these horrible things. In fact, we're in the process of developing what's called a prevention of adhesive arachnoiditis document, and most of it's going to function on what to do when you have discs that you know are protruding. So anyway, that's what happens. And again, here it is. You have the spinal cord, the canal, the nerve roots are hanging down, and they get into an inflammatory adhesive mass in which the nerve roots are attached to the spinal canal covering, and the nerve roots coming out of it are impaired. They are damaged. They might even be dead. They may not function. And it's because these nerve roots are trapped in this mass is what causes you to have the symptoms like weak legs, your bladder doesn't work, your sex organs are dysfunctional, your bowel doesn't work, you hurt all the time, you have bugs crawling on you, you have burning feet. It is this mass involving these nerve roots that gives you these symptoms. So that's fundamentally, in a simple rundown on how everything does work. Now, I'm not here to make people experts on reading MRIs, but MRI technology is what has given us the ability to have this seminar. MRI technology was invented again, as I said before, in 1987, but since then there's been progressive technical advances to where today we can take the MRI and look at it and really get a story on what's happened to an individual to give them either adhesive arachnoiditis or one of the other inflammatory diseases of the lower spinal canal. But it all goes back to the picture, and this is what this picture is. This is what a MRI, and you're going to see some in a minute, looks like in what we call the axial view. Now, what's the axial view? The axial view is the head to toe view in which you're looking right down the pipe. You're looking right down the spinal canal end to end, not from the side. And when we look end to end, you see this picture. Here's your big vertebra, your big bone. Here's your spinal processes. That's the thing you feel when you rub up and down your spine. And in the middle is the spinal canal. Now, the good Lord puts it inside these bony structures because it's too valuable. He or she wanted us to have a very protected spinal canal. What's interesting about this, however, is that the nerve roots that come out of the spinal cord are in a very symmetrical, structured pattern. And here you see them, and they are paired. on the right side and the left side. That's why you have activation of your right leg or your left leg or your right arm or your left arm. And these nerve roots are paired. One of the nerve roots is for incoming electricity. One is for outgoing electricity. But they're paired and they are symmetrical. Now, anatomists in some basic science departments in universities have actually done what we call mapping, to where we actually have a map on exactly what the nerve roots are to look like at each level of the lumbar sacral spinal canal. Now, today we have something called a neuroradiologist. They're getting quite expert at looking at these. A handful of researchers like myself have been studying these and indeed have actually mapped these nerve roots. Now, I'm going to show you next a normal picture. Here is a normal person with normal nerve roots, and this is an axial view. Again, I'm going to back up. Here, back up. And here. Now, these are the nerve, this is the bone, your big vertebra. This is your spinal processes. This is the canal. The white is spinal fluid. Now, we call this contrast. Today, a person can have a dye injected to have the spinal fluid show up as white, or some of the high resolution Tesla instruments can actually have the fluid show up without you having to take dye. So these are great advances, but they show these nerve roots right down to them. A normal person has about 24 of them, and there's as many on one side as there is on the other. They're symmetrical and they're round and they're paired, but they have a certain size. Now, I don't expect anybody seeing this webinar to know the size, but after you look at a few of them, you kind of know whether the nerve root is swollen or whether it's normal size. This is perfectly normal at the level of the lumbar 1 or 2 spinal vertebra. Now, here is a normal appearance at the L4 to S1, the danger area, I call it. And here you have the nerve roots, they're on the same on both sides. They're the normal size. They're symmetrical. That's perfectly normal. Now we're going to look at an abnormal one. Here is unfortunately adhesive arachnoiditis. You have the big vertebral bone, the spinal process. Here is the spinal canal, and there is the mass. There's a mass, and there is a mass. Right here, you see, at about L4 or L5, a clump or mass of nerve roots embedded in a scar here of adhesions and of inflammation. And this, it's not really too visible, but around here is the arachnoid dura covering, and it's attached to this covering by adhesions. This is a disastrous picture. It's catastrophic. This individual has to be in treatment. This individual has to get some pain relief, and it has to cut down the inflammation. Otherwise, this mass can grow and other masses can form. Be clearly informed. This clump or mass of nerve roots attached to the covering can get bigger, and if they're not under treatment to suppress the inflammation and prevent further growth of adhesions, the mass can grow, entrapping more nerve roots, and that brings more misery, more suffering, more disability, and earlier death. So that's why we're having this seminar. We need to prevent this, and when somebody does get it, needs to be at least in the new treatment that's been developed for this condition. Okay, now here is a side view. We call this a sagittal view or lateral view of somebody who has the new MRIs. The white here is the spinal fluid. This is the spinal cord coming down, and below that are the nerve roots. These are the bones, the vertebra. These things here are discs. Now, what's sad about this case is that here is the adhesive arachnoiditis mass. You can see it right here. It almost looks like a big black thing. And what's happened, this mass is actually eroded through the spinal canal covering, and it's leaked. And here is spinal fluid out in the tissues between the spinal canal and the skin. This is the skin, and here this mass is backing up the spinal fluid. Now, just a quick thing here. Years ago, I wondered why all the people with arachnoiditis complained about blurred vision and headaches and ear ringing when the problem was clear down in their lower back. And the reason they have that ringing in the ears and that imbalance, that headaches, even inability to think, blurred vision, is because the spinal fluid is supposed to flow back up and around the brain in a steady flow and turn over every 4 to 6 hours, but this mass is backing it up. Any disturbance in the flow may give you headaches, blurred vision, ringing in the ears, poor balance, or the inability to even read a newspaper. And so this is tragic. Also, if this mass erodes through the canal and you get what I call leakage or seepage, you're going to have terrible pain in here, and it's going to erode tissues, and I'll show you some pictures of that in just a second. So anyway, this is what it's all about. You have a mass, a backup of spinal fluid. Here you even have some discs that are starting to protrude a little bit. You have backup of spinal fluid. In other words, this person needs a lot of help and a lot of treatment, both from their local physician, what help they can get, as well as self-help groups. In other words, this can be helped. It looks terrible, but let me assure you, this person's actually doing pretty well in treatment. Okay, here's just some other pictures to give you some idea of what we're talking about. Again, masses. Right here, clumps, masses. This is a 46-year-old male post-lumbar fusion with constant disabling pain and partially paralyzed left leg. Now, I'd like to say one thing right now. Surgeons, anesthesiologists are being blamed all the time for causing this. That's much, much too simple of a statement. The surgeons and the anesthesiologists do these procedures because they are medically indicated, and they may not have any option. And up until lately, we haven't had such things as microdiscectomies. We haven't had such things as radioablation as opposed to epidural injections. In other words, everybody knows that these procedures increase the risk, but doctors have had to do these things because that's all they had. They're developing a lot of new techniques. They're well aware of this, or at least the neurosurgeons and orthopedists are. And today I see surgery being done without much risk. But it has, it's just one of those things. If that disc slips too far into the canal, the surgeon's going to have to operate and just take the risk. And so, again, there's been a lot of statements and a lot of blame that really aren't justified. Some are. There's excessive surgery, there's excessive epidurals, but I think that's kind of coming into balance. Now, here is a case that I want to dwell on for a couple of minutes, and that is this. Here was a case I received a few years ago, and several doctors, including top-flight radiologists, had looked at this case and couldn't decide what she had. And it turns out this lady has all of the symptoms of adhesive arachnoiditis, but her MRI is equivocal, as we call it. Is this a clump? Is it stuck to the lining? One doctor says yes, another doctor says no. But one thing is clear. This is abnormal. It's asymmetrical. The nerve roots are a little swollen. Some appear to be stuck together. And so we would call this cauda-equina inflammatory disorder, or some people like to use the term cauda-equina inflammatory or cauda-equina syndrome. Either way you want to call it, cauda-equina inflammatory disorder or chronic cauda-equina syndrome, I don't care. What is important is that this person has the same symptoms as adhesive arachnoiditis, and she is at the preliminary stage, and if you don't get treatment to her, she will probably go into adhesive arachnoiditis. So today, we have the spectrum of this. Now, we'll go to that in a second, but now let's cover the tragedy, and that is the complications of an inflammation in the spinal canal and the complications of adhesive arachnoiditis. First off, intractable pain syndrome. The pain of this, in my experience, is much worse than metastatic cancer pain today. Didn't used to be, but today There's just no worse pain than adhesive arachnoiditis, and they get the whole syndrome where they affect their immune system, their endocrine system, their cardiac system. In other words, horrible pain. They can develop paraparesis or paralysis of their lower extremities. Bowel, bladder, and sex organs can become almost non-functional. Endocrine failure. I'm going to say more about this in a couple of minutes. The stress of this disease is so great that the adrenal gland and the pituitary gland and the gonadal glands may not be able to keep up with the need for the hormones, and therefore endocrine replenishment really has to be a big part of treating this disease. You're very impaired with this condition if you end up with a severe case. Your social, financial, personal care impairments, you become bedbound, and lastly, you die at early, young, miserable age, at least in the past. Fortunately, we're doing a lot to prevent the early deaths. Even in the last 10 years, I've seen people really getting better, and at least they're not dying at age 40 or 45 with this disease. They're living out a longer life because we're getting some help to them. Now, here's what I have alluded to, and I want to focus on for a moment. Adhesive arachnoiditis is the bottom line down here because every one of these conditions is inflammatory, and they're in the lumbar and sacral spines. And so this is an age in which this webinar really should be called Intraspinal Canal Inflammatory Spectrum, because the discs may be inflamed and they may protrude. Arachnoiditis by itself means that only the cover is inflamed, not the nerve roots. You may have these cysts. Now, these cysts may look like they're genetic, and they may occur almost because you've got Ehlers Danlos Syndrome, or they may either cause or be the result of inflammation. And so anyone who has Tarloff cysts, again, is in this category. And the cauda-equina nerve roots themselves can become inflamed. There's a condition called acute cauda-equina syndrome. That's where the nerve roots are so compressed by a protruding disc that you have to have emergency surgery. We're not talking about that. We're talking about the person who has inflammation and the same symptoms as adhesive arachnoiditis that may go on for months or years. And lastly, the worst condition, adhesive arachnoiditis. So all of these conditions need to be treated. They're all inflammatory, and this is the age of identifying and treating lower spinal canal inflammation. Now, here are the symptoms. Now, these symptoms are identical for whether you have chronic cauda-equina inflammatory disorder or whether you actually have the adhesive arachnoiditis. And every medical practitioner, in fact, every patient and family really needs to know this because it's kind of a typical profile. In fact, when I first started seeing these patients, I wondered if they were kind of nutty, because people would come into the office and complain about water dripping on their legs or insects crawling on their buttocks, and I thought they were a little nutty. Well, I found out that if you hurt those cauda-equina nerve roots down around L5 and S1, you get this sensation of water dripping on you once in a while, or insects or bugs on you. And also, because those nerve roots are entrapped in a mass, electricity gets released intermittently, and therefore you get the stabbing or the shooting pains into your legs or your buttocks. And because you're right there where you sit, people get some relief by standing or laying down. Most people who have this condition can't sit for more than 10 or 15 minutes. You're going to have a nice big soft pad, and you're going to have to stand a lot. Also, burning feet. Now, you can get burning feet from diabetic neuropathy and some other conditions, but burning feet is very typical in this condition. And next, urinary dysfunction. There's about 26 nerve conditions from the lumbar and sacral spinal canals to the bladder. And therefore, practically everybody who has either cauda-equina syndrome or adhesive arachnoiditis of any severity at all will have either some urgency, incontinence, or frequency. Urinary dysfunction is part and parcel of the package. And lastly, blurred vision. So there you have it, folks, the symptoms. Now, when you go into a room and you hear that everybody in the room has back pain, those people who have those symptoms have the arachnoiditis. And that's something that I want every nurse practitioner, osteopath, chiropractor, physician needs to know today. This is the profile. Physical findings. In the lower extremities, for those of you who are watching this who do physical exams, you'll see some non-specific things. There's no specific physical finding with arachnoiditis. Some people think that if you tap on the spinal process, you may get some pain. That's a good sign. But you may have any of these things, but they're not all specific. Because the reason why they're not specific is because the nerves that are entrapped are all different in different people. And so therefore you may get a foot drag in one person, a wide gait in another. You can't do straight leg raising on another person, or a reflex on another, but you'll usually find something. If you have a patient with this who cannot raise their arm straight up, that is a sign that they've had spinal fluid leakage or seepage. If that spinal fluid gets into the tissues, it is toxic. Spinal fluid naturally is filtered by lymph nodes in the neck. It is never to get into the general circulation or into tissues because it is toxic. And if it gets into the general circulation, it'll cause autoimmune manifestations and give you such things as Hashimoto's, carpal tunnel syndrome, fibromyalgia, and other autoimmune symptoms. The back itself may get terrible distortions. And my one message for those of you who do physical examinations, if you see a back that looks distorted, muscle groups are abnormal, there's abnormal leaning, creases, skin indentation, think of adhesive arachnoiditis. Here's some examples. Here's somebody here who's got, you can actually feel the spinal fluid leakage here. It was soft. They've had rods in them that are starting to penetrate. In other words, not a pleasant sight. Here's another one. You see this big crease here. You see folds here. When you see this kind of physical logic distortions, think adhesive arachnoiditis. Another one here, creases. This is obviously had surgery and caused some of the distortion, but you see the indentation here. And another thing that happens is this. You get an indentation right down the middle of the back or even off to the side, and that's caused by spinal fluid leakage and scarring in the subcutaneous tissues. Laboratory findings. These are studies that I've been very involved with. And you may see elevated inflammatory markers, and you will probably see decreased hormone levels of these four. Now, I want to go over the research findings that we've learned on this, because these research findings are the basis of the modern day first generation treatment. Now, I haven't done all these, but this is a summary of research over the last decade or so that has given us the ability to develop a management approaches to this disease. Number one, we now know that few drugs or hormones cross the blood-brain barrier and enter the spinal fluid. In order to deal with inflammation in the lower spinal canal, you've got to get drugs that enter the spinal fluid. Spinal fluid itself carries nutrients and drugs to the target sites or to the receptors in the lower spinal column. One thing I want to make a mention here, only some corticoids will cross the blood-brain barrier and get into the spinal fluid. The best ones are potent are methylprednisolone and dexamethasone. Prednisone and hydrocortisone are lesser. So only a couple of these corticoids really get across the blood-brain barrier and enter the spinal fluid in adequate amounts to be very effective. You hear a lot today about stem cell treatment. Stem cell treatment's been kind of iffy up till now, but I can tell you that there are some research studies in which they're using stem cell extracts and having it be given through the nose or something to get into the spinal fluid, and the early results look promising. The bottom line is this. In order to treat these lower spinal canal inflammation, you can't just depend on the blood supply going to the spinal cord and the nerve roots. You've got to depend also on getting drugs into the spinal fluid. Interestingly, we have a series of compounds that have been shown initially in animal studies to suppress neuroinflammation. And I've listed them here. Now, what's interesting about them, they don't have a darn thing in common as far as chemical structure or classification, but all of these seem to work. One thing that has come out of that is naltrexone. If a person is not on opioids, naltrexone has become the first drug of choice in a dose of somewhere between 1 to 14 milligrams a day. It's usually given in 2 dosages a day. And most physicians start off with, let's say, 1 milligram twice a day. And naltrexone is turning out to be an excellent drug for all the spinal canal inflammatory disorders because it suppresses inflammation, gives you some pain relief, and it also suppresses the immune system. In other words, you get 2 or 3 good things about naltrexone in one. It doesn't work on everybody, but it's probably the most consistent agent we have. And all of these others are used by physicians today in some patients. Now, another major breakthrough has been the discovery that the spinal cord and probably the nerve roots themselves make a set of hormones which are now called neurosteroids. And these include pregnenolone, DHEA, it's dihydroepiandrosterone. You don't need to know the name, but that's what it is. Progesterone, allopregnenolone, estradiol. These are neurosteroids. And the purpose of these, or at least the good Lord's purpose of these, is to suppress inflammation and promote regenesis or growth of the neurons. Therefore, in my way of thinking, in order to treat this, you need to take some of these neurosteroids. Some are over the counter and simple, like pregnenolone and DHEA. They're easy to give and quite safe, and should be a part and parcel of treatment today. Spinal fluid flow. There are certain things that people can do, we think, to increase spinal fluid flow. Little things like, just plain old walking on a trampoline or rocking. Dr. Janet Travell had John F. Kennedy, who apparently had arachnoiditis, rock in a rocking chair every day. So rocking chair therapy looks like it does help spinal fluid flow. Time doesn't permit me to go through all the things that I recommend to help spinal fluid flow, but we've got a set of those that anybody can obtain, and we do think they might be a real asset to treatment. Lastly, here's a new surprise. Electromagnetic energy waves, sometimes called energy fields, have now been shown to suppress inflammation in and around the spinal canal. Now, what is electromagnetic energy? Electromagnetic energy is not electricity. It is not magnetism. It's a combination. An electronic energy wave or field is half electronic and half magnetic. And today we're getting good use out of this, not good use yet, it's new, but research is showing that these electromagnetic energy waves will suppress inflammation, and instruments are being developed to be a new addition to the treatment of lower spinal canal inflammation. Radio waves are the one that I've liked the best personally because it penetrates quite deep. Laser is also an electromagnetic energy wave, and I'm not quite sure how deep it penetrates, but radio waves and laser waves are being used with good effect right now in lower spinal canal inflammatory disorders. I want to close out with some other research findings to let you know that we just didn't dream all this up. We have done a number of studies on inflammatory markers, and we can demonstrate that the inflammatory disorders of the spinal canal do put out some inflammatory markers that can be measured in the blood. And today you can get something called a cytokine panel, which is a little more sophisticated than a regular C-reactive protein or erythrocyte sedimentation rate. But all these may go up in adhesive arachnoiditis. But here's the catch. They don't go up consistently. Just because the blood is negative doesn't mean there's no inflammation there. If they're positive when you take them, you can kind of follow it clinically. It's a good marker, but you can't ever assume that inflammation goes away. Now, I want to make one comment here on the best way, in my opinion, to determine if there is inflammation in the lower spinal canal, and that is to do what's called a 6-day corticoid test, usually a Medrol 6-day dose pack, or take 2 or 3 shots of ketorolac, that's Toradol, and if a person gets better, they've got inflammation. In other words, a therapeutic trial of the most potent anti-inflammatory agents is a pretty good test, and I like to recommend that at all times. These hormone levels drop in adhesive arachnoiditis. Now, I'm sort of saving the bad news for last, and that is this. I do not believe that adhesive arachnoiditis can be well managed without some of these hormones. Now, doctors don't like to take or like to prescribe corticoids. Patients don't like to take them. I don't like to prescribe them. But at this time, we believe that low-dose intermittent use of certain corticoids are going to have to be essential in the management of adhesive arachnoiditis until we get biologics or something new. Why? Bank this one. The most potent over time suppressors of neuroinflammation are the corticoids. This is well documented in literature. These other hormones also have a good place, but I did want to bring everybody the news. Number one, the studies show that you can use low-dose corticoids safely. There's a new study out on 2,000 patients showing that it can be done. Now, I recommend low-dose Medrol or dexamethasone 1 to 3 days a week. You can't hurt anybody, but I think these corticoids at this point are almost essential for the treatment of adhesive arachnoiditis. I hope I can come back later and say I'm wrong, but at this time, I just have to bring people the bad news, and we could help get people on different methods to use low-dose intermittent corticoids. I don't recommend them every day. Everybody knows the side effects, but low-dose intermittent use I think is necessary, and people who get flares of adhesive arachnoiditis are going to have to use something like a 6-day Medrol dose pack, or they're going to have to use ketorolac injections or both, along with maybe an injectable opioid in order to break flares. These are just some of the sad parts about the management of adhesive arachnoiditis. It's time that we just kind of get over it. Years ago, we had to manage rheumatoid arthritis this way until we had biologics. I think the same thing is happening here with adhesive arachnoiditis. We're going to have to use the corticoids for a while until we get some of our good pharmaceutical companies to come up with some good biologics. Next bit of research, which is a new welcome thing, and that is, here is a multi-center randomized sham-controlled double-blind study of electromagnetic energy with a radio wave in post-operative pain. And the results were, I don't want to say they're too good to be true. Even if they're half true, it shows you that this is an area of research and a clinical treatment. The people's pain in the legs got better, in the back got better. But the thing that impressed me the most was that the C-reactive protein decreased in those people who got radio wave electromagnetic therapy, which was pulsed, and it was made, the trade name was Provant, and they just happen to be one of the devices that are not available to the general public yet. It's research, it's available in the veterans hospitals, but nevertheless, C-reactive protein decreased. Those who didn't get it increased. And this was a very well done double-blind study, but it tells us something, and that is electromagnetic energy really is a fact. It really can be sent from the skin with a device into the spinal canal. It's a wave of the future, and I'm hoping that we can bring this to everybody who's got adhesive arachnoiditis or Corticoid chronic syndrome. Everybody should have advantage or take advantage of these devices. In summary, adhesive arachnoiditis is a severe intraspinal canal inflammatory disease which entraps the corticoid nerve. In other words, it's two tissues connected to each other. Adhesive arachnoiditis is emerging in every community. You no longer can deny that it exists, say that you've never heard of it, it's not around, it's somebody else's problem. It's the problem of every medical practice and every family who's involved, and every self-help group that's involved. And incidentally, the self-help groups are doing a yeoman's job in doing education these days, and I want to thank all of you out there who I know are watching. Adhesive arachnoiditis has a very typical, unusual bit of symptoms that should be known to every medical practitioner. Water dripping on the feet, bugs crawling, burning feet, blurred vision. I can't think of anything else that gives you this profile except either the Corticoid inflammatory syndrome or adhesive arachnoiditis. And lastly, we're developing some treatments. They may not be the best, and we hope they're going to get better. And unfortunately, we have to use some drugs that are a little scary, but we're going to have to use them because it's a scary disease, and it's the best we have at this time, but we are getting results. I'm going to close with one statement. 10 years ago, when I started doing this and first started trying the hormones, trying ketorolac, trying things that scared me, really, I thought that, gosh, what's going to happen? I saw people who were paralyzed start walking. I saw people get out of bed. I've seen people who had the Corticoid syndrome never develop adhesive arachnoiditis. We've seen a lot of positive things. And so I'm very encouraged about it. I think we're going to get better. I want to thank the people who put on this webinar. And lastly, again, I want to thank all you folks out there who are in the groups, Donna and Gary and Ingrid and Zip and Nancy and everybody who's been out there helping me. Thanks so much. I look forward to a better webinar at some time in the future, but right now we're making headway. Good day. Thanks so much.
So the first question is, what are the differences between tethered spine and adhesive arachnoiditis? Are you in favor of those inversion devices for prevention of and treatment of some of the compression issues that you indicate are fundamental to development of adhesive arachnoiditis?
Let me say this. Today we have people with everything from tethered cords to cysts, trauma. We have any number of rare, tethered cords are very rare. But if you have a rare condition, that the surgeons have to operate, they have to do something with your spine, and that you're left behind with this inflammatory disorders. And that's why I'm making a point that the inflammatory disorder is what needs to be treated. Tether cord surgeries, Tarloff cysts, all the surgeries and the outcome of some of these things are not good. You can end up with adhesive arachnoiditis, but the first and foremost thing to do is how much inflammation is there. In other words, you need the blood test. That's number one. You need the physical exam. You need an X-ray read to determine what's happened to those nerve roots. And then lastly, you need some trials with the corticoids and the ketorolac to find out whether you've got inflammation. In other words, I hate to say it, but when you have this rather dramatic surgery, and keep in mind that today neurosurgeons and orthopedic surgeons, people criticize them a lot, but they do surgery that years ago they wouldn't even have attempted. They save people's lives. Unfortunately, sometimes they've got to do some heroic surgery which leaves these conditions behind. And our job is to try to deal with those. So to say that a tethered cord or a Tarloff cyst is going to give you just this condition or just that condition is not true. You may get any one of those things in the spectrum.
Thank you. Another question, can a fentanyl pain patch help?
Okay, fentanyl is an opioid, and I didn't get into the pain treatment because this might surprise people today because of the opioid crisis. The opioid crisis was definitely a problem. Everybody knows that. And fentanyl is the most potent of the available opioids. And pain treatment today is symptomatic, and it has been since the fifth vital sign 20 years ago. And so pain treatment hasn't changed really very much. And people with adhesive arachnoiditis are going to have to avail themselves with whatever severity of pain they may have to take whatever is available. Fentanyl patches are used as kind of a last resort for pain treatment. They're widely used, very effective for some people, but again, fentanyl is a symptomatic pain relief compound. Some people with arachnoiditis are going to have implanted electrical stimulators. Some are going to have implanted intrathecal pumps in which fentanyl is given right into the spinal canal, or morphine is given into the spinal canal. I'm hopeful that we can prevent adhesive arachnoiditis from getting to that stage. But for those people who are at that catastrophic stage, fentanyl patches and some of these unfortunate pain treatments are going to have to be used.
Okay, another question. How soon after a trauma, for example, an injection, can this develop?
This comes up a lot today, and I didn't have a chance to cover it, but anytime that you do anything to the covering of the spinal canal, you take a risk to develop inflammation. Now, the easy way to answer this is to the person, for example, whoever asked the question, have you ever been bitten by a bug? Have you ever gotten an infection with a splinter? And in other words, if you got a splinter in your thumb in the morning, was it red by the afternoon? And the answer is, could have been. The same way when you get trauma or a needle stick or anything that happens to the spinal canal covering, it's the same process as putting a splinter in your finger. Inflammation may start as soon as 1 hour, or it may be delayed a couple of days. But the spinal canal covering is never to be injured, tampered with, unless you just absolutely have to do so for medical purposes. In other words, the inflammation can start and arachnoiditis can begin within hours after any kind of needle stick or damage to the spinal canal covering.
Okay. And here's another question. Which medical discipline should take the lead in managing this syndrome?
My favorite question, incidentally. Today, it's whatever physician, nurse practitioner, chiropractor, or osteopath is interested. There has been no one specialty claim this disease yet, and I'm out campaigning. So I believe that this condition should be the purview of the rheumatologist and the neurologist. It is not a pain condition. It should be looked at as a disease, and rheumatologists and neurologists should be the specialists. But let me say another thing. This is a chronic lifetime condition, and every general practitioner, primary care doctor, nurse practitioner needs to know how to do the management. We can't depend on cardiologists to manage everybody with atrial fibrillation or heart failure. We've got to depend on the primary care family doctor to do a lot of the yeoman's work. And that's the same with this disease. For anybody watching this, my answer when somebody wants to go to a doctor or find a doctor to treat this, I'm going to tell them, go to your family nurse practitioner, physician assistant, osteopath, or family doctor. Don't go looking for a specialist. Go to your local family doctor. They'll know people who are interested, or maybe they get interested. We have doctors and nurse practitioners and osteopaths all over the country right now getting interested in this disease, rightfully so, and a lot of them are coming up with some new ideas. I'm going to tell you something. There is not a week goes by that I don't hear from my network of doctors and patients and families and nurse practitioners who are coming up with something new, a new idea. It's very exciting. I see nothing but a kind of a groundswell of people trying to help. Everybody recognizes this. And again, I want to take a chance again to say thanks out there to all the social media groups. Donna and Nancy, I hope all of you are listening, because they've really fostered this whole movement. And on top of that, they've been on my case to keep me moving. So I thank you for it.